interacting is a little bit tough via teleconference. So I have no problems with people interrupting, or feel free to chime in, whether that's via chat or just unmute your mic too, that works. So we'll go ahead and get started. So the basics, let me move this out of the way, hold on. All right, so just kind of an overview of my approach to knee MRI. First of all, anatomy is really the key to a lot of musculoskeletal radiology. Well, first of all, I should start off with what is musculoskeletal radiology? Can any of you guys tell me kind of what it is that I do on a daily basis? Nobody knows. That's fine. That's good. So radiologists in general do a lot of interfacing with clinicians. So we think about physicians as being kind of the interface with patients. Radiologists are a little bit different in that most of our patient interaction is instead replaced with kind of physician interaction. So I spend a lot of my time at the University Orthopedic Center interfacing with the PM&R doctors and the orthopods, with athletic trainers, and we also interface with infectious disease and trauma doctors and ER doctors and rheumatology. So we cross a lot of different kind of boundaries and work with a lot of different subspecialists. All of it is kind of in regards to the bones and joints and muscles, et cetera. So anatomy becomes really important in radiology, and that is especially true for musculoskeletal radiology. So I remember taking anatomy as an undergrad and thinking, I know every muscle in the body and I know all of these structures and it's so wonderful. And then you get to medical school and realize that you learned about 10% of it when you were in undergrad. And then you get to radiology and realize that you learned about 50% of it in med school. So there's always more anatomy to know. The reason it's so important in musculoskeletal radiology in particular is because abnormalities, present themselves pretty apparently on MRI. It's just kind of knowing what's injured that becomes important, and that's why anatomy is really key there. So the next kind of key is to use the protocol. We'll talk a little bit about MRI protocol. I know that's something that gets discussed more in your textbook that you're using for this rotation. And then knowing the mechanism is actually really helpful. This is especially true for sports. So a lot of knee MRI is sports injury related, and so we'll look at that specifically. And then finally, the exam and the history matter, but so do the examiner and the historian. So anybody who's done a pediatrics rotation for a kid who is not verbal, it makes it very challenging to figure out why they're limping or why they're having pain, et cetera. So having kind of a good history and a good exam are very helpful, but you kind of have to take things with a grain of salt depending on who's giving you that information. So first of all, we're going to do an anatomy quiz. This is not like your official quiz. This is just a quiz, so we can test your anatomy. So write this down, whether it's on a piece of paper or on your just typing it out or whatever the case is. Like I said, if you understand the anatomy and you know the anatomy well, identifying an injury and kind of diagnosis becomes much easier. So we'll start with the muscles and tendons. So it's a little hint here, muscles and tendons only. And there's a lot of these, so I'm going to go through them pretty quickly. Okay, so identify the muscle that is shaded in red, muscle or tendon, I should say. Give you a few seconds to do that. Okay, next. Moving on. All right, next structure here. Okay, I think there's a couple more. All right, and then just in general, last one here. This is not a muscle or a tendon, but that's okay. All right, so let's go through these. You guys get some of this anatomy during your bone, muscle, joint course, is that right? And yeah, it's probably been a couple of years since I think most of you guys are third and fourth years, but that's okay. It's a good refresher. So first of all, we're looking at an axial slice here. It's as though we're standing at the foot of the patient and looking up towards their head. That's how most imaging is oriented. And then we have a more sagittal sequence here, as though we're looking at the patient from the side. This being the anterior aspect, this being the posterior aspect, and then it's as though the patient's laying on their back. So this is the anterior, this is the posterior aspect. So the first one is the vastus medialis. So given a single slice in an axial plane, it's actually really hard to tell exactly where we are. So we have to remember that there are two bones in the lower leg, right? This is tibia and fibula is kind of hiding back here. And there's one in the leg, and that's the femur. And so on this axial slice, we only have one bone. So we know we're in the thigh or in the upper leg. Telling medial from lateral can be challenging. There's a couple of tricks. First of all, the medial soft tissues are always a little bit thicker than the lateral. So we have more subcutaneous fat. We have more musculature distally on the medial aspect of our leg. And so that's how we know we're on the medial side. So this one's our vastus medialis. That makes this one the vastus lateralis, right? Because this is the lateral side. And these kind of combine to make up this quadriceps tendon. By this point in time, the rectus femoris and your vastus intermedius are already a tendinous component. And so all you see are just kind of the distal aspect of the myotendinous junction of the vastus medialis and lateralis, and those combine to form the quadriceps tendon. The quadriceps tendon just kind of continues into the patellar tendon. So the patella is a sesamoid, right? So it's embedded within this tendon. Even though we call these separate tendinous structures, they really are contiguous, with the patella being the biggest sesamoid in our body. So that's the patellar tendon. And then we're going to go into the posterior medial leg. So this is the other way that you can tell this is the medial side, as we have kind of our three tendinous structures that extend distally to insert in the pes anserine and on the tibial. So this is sartorius, gracilis, and semitendinosus. So segrace T is kind of the mnemonic that we use to remember those. Semitendinosus at this level in the leg is much more tendinous. So we have this kind of tendon unit. There's not much muscle left. But it is in close proximity to the semimembranosus, which is much more membranous at this point in time. So there's semimembranosus. And then the last of our hamstring musculature coming from the lateral aspect of the lower leg is the biceps femoris. So we have two heads here. This is actually the long head, despite the fact that it's much smaller at this level of the leg. And this is the short head that goes on to insert on the fibula. And then the lower leg muscles, these are coming up from below. So this axial slice is actually clear up here. So we don't see any of these lower leg muscles, but we can see the gastrocnemius muscles are most superficial muscles of the lower leg. Just deep to that is this big muscle belly of the soleus, and deep to that is the popliteus. We know this is popliteus because the tendon of popliteus actually goes intra-articular. It's kind of a funky muscle. And we see that just hugging the posterior aspect of the tibia there. And finally, not a muscle or a tendon, but the popliteal artery and vein, as well as the tibial nerve, kind of live in this posterior aspect of the leg. So questions about muscles or tendons? Nope. Okay, we're moving on to ligaments. The rest of these are much shorter anatomy quizzes, but please continue to participate. All right, do you guys have enough time on ligaments? There are actually quite a few ligaments in the knee. There's probably about 10 that we're not going to talk about, but there are 4 major ones that I feel like everybody should know. These ones are probably ones you've heard of and seen before, the anterior cruciate ligament. So again, we have a sagittal sequence here, coronal as though we're looking at the patient from the front. So these are 2 sagittal to 2 coronal sequences. The anterior cruciate ligament is one of the major stabilizers of the knee. I know you've heard about it. We can see it coursing along from the posterior aspect of the distal femur to kind of the tibial tubercles here. It should parallel what we call Blumensatt's line. So Blumensatt described this on radiograph, but it's actually just kind of a superimposition of this thick cortex of the intercondylar notch here. And it should parallel the ACL. So when you have an ACL injury, you'll use this Blumensatt's line to kind of judge if this ACL is in the appropriate configuration. So we'll look at that a little bit further. So if the previous one was the anterior, this makes this the posterior cruciate ligament. So again, it attaches our femur to our tibia, but it's much further posterior within the joint. We always show these ligaments on these sagittal sequences because you can kind of lay out the ligament in its entire course. But when you're evaluating a knee MRI, these are actually the least sensitive in detecting a ligament tear. So you really have to utilize your other sequences, your coronal sequences and your axial sequences to make sure you see that ligament in continuity. The medial collateral ligament, again, more subcutaneous fat, more soft tissue, so we know this is the medial aspect of the knee. We can also see the fibula along the lateral aspect of the knee in this case. And our collateral ligaments, again, attach our femur to our tibia, but they're along kind of the medial and lateral aspect of the joint line. So this is the medial collateral ligament. And finally, the fibular collateral ligament. Some people will call this the lateral collateral ligament proper. I like to call it the fibular collateral ligament because it helps me remember where it attaches to. There are actually a number of other ligaments that make up the lateral collateral ligament complex. So you can call it lateral collateral ligament proper, or you can just call it the FCL in this case. So that's it for our ligaments. All right, and then in our final category, kind of other structures. Let's go through these pretty quickly here. All right, so for our other category, these are kind of the other soft tissue and osseous structures. So the medial meniscus, again, on our medial side of the knee on our axial sequence here. We're a little bit distal than our previous axial slice. We're probably right through the level of the joint line here. And you can see this more C-shaped medial meniscus. It's a little bit larger in the anterior posterior dimension than your lateral. And the meniscus always shows up as these nice sharp triangles. So I always tell our residents, remember how you drew a triangle in kindergarten. These should be nice sharp corners, all right? Because we're gonna see some abnormal examples here in a minute. And one of the first things you lose are those points of that triangle. So here's that medial meniscus. The lateral meniscus is a little bit more disc-shaped. It's a little bit flatter in that anterior-posterior dimension, but it still maintains that nice triangular morphology when we're looking at it in these coronal and sagittal slices here. And this gray stuff is actually the cartilage. So you can see how thin it is and sometimes difficult to see. So the bone itself has this nice marrow component, and then we have this thick cortical line. And superficial to that, we have this gray stuff, and this is actually the cartilage. You can see it on kind of both sides of the joint, depending on where you are and which, within the joint space and the slice, it kind of has a different appearance, but it should always have this kind of uniformly gray look to it. And then the bones, our femur, our tibia, our patella, and you can see a little corner of fibula here. And that's kind of everything that you get to see on a knee MRI. So now you guys are the anatomy experts, and so the pathology portion of it should be a piece of cake. So let's talk about MRI protocol just real quickly. MRI, I think, is a very complex topic, but one of the important things is try to remember the terminology, and that will help you when describing some of these findings and evaluating some of these cases. So we try to use consistent terminology. The challenge is there's a lot of interchangeable words, right? And so we'll say, oh, there's increased signal, or it's bright, or it's white, and those all equal hyperintensity. So just remember that hyperintense means there's more signal. It often appears whiter to our eye, and it's brighter. Conversely, the hypointensity is darker to the eye. It looks blacker, and it's a decrease in MRI signal. And then contrast is typically something that we administer to the patient intravenously. Usually you can do oral contrast as well. For MRI, it's almost exclusively intravenously. And the contrast agent actually contains a heavy metal called gadolinium. And that gadolinium gets taken up by the vasculature, and you can see areas that have increased blood flow or increased perfusion. So we talk about that as enhancement. So structures that take up all of that contrast agent are enhanced or end up being brighter or whiter compared to the pre-contrast imaging. So let's talk about the knee MRI protocol. We pretty much only perform 5 sequences for a knee MRI. They come in different planes, meaning that we have an axial, 2 coronals, and then 2 sagittal planes. So we kind of get to see the joint from many different views. And we also use a variety of different sequences, and that's to highlight kind of different pathology. So I'm going to describe them in terms of what is bright. So we call that sensitivity. So if fluid is bright on a sequence, we call it a fluid sensitive sequence. So you can just see a little tiny bit of joint fluid on this proton density, or a PD sequence. Most of our sequences in musculoskeletal radiology are fluid sensitive sequences. And that's because most pathology shows up as bright abnormality. So we think about edema, hemorrhage, contusion, all of those things, ligament tears, they're all going to have increased edema and fluid content. And so they're going to be brighter on these fluid sensitive sequences. So these are both PED, or proton density, and T2 weighted sequences. There's one fluid dark sequence that we perform, and that's a T1. So you guys have probably heard the terms T1 and T2 before. The biggest difference between the T1 and T2 are the fluid properties. So fluid on T1 is hypointense, or dark. There's not very much fluid in this case, so it's actually really hard to see. And then finally, fat is kind of the other component that can help you determine which sequence is which. The challenge with this is many sequences have an intrinsic fat hyperintensity, meaning fat is bright. So on your T1 sequence, remember, fluid is dark, fat is bright. On your T2 sequence, fluid is bright, but fat is also bright. We perform specialized techniques to actually suppress the fat, so that the only thing in these cases that is bright is fluid. Hopefully this is not too confusing, but really just looking for areas of fat that are bright. So this becomes a fat sensitive sequence. This becomes a fat sensitive sequence. Looking for areas where there's fluid bright. So this is a fluid sensitive sequence. You can see there's fluid bright here. There's fluid bright here. So I think about it in terms of fat sensitive and fluid sensitive. And same thing, you can see the fat is dark here. So the fat is suppressed in these particular sequences. Okay. So this is an important thing to know for most MSK pathology, including injuries. So this is a fluid sensitive sequence. It's also known as a STIR. This is a T1, and then this is a post-contrast sequence. So for most pathology in MSK, you are going to have T1 hypointensity, T2 hyperintensity, and contrast enhancement. So this happens to be an insufficiency fracture in a tibia. We have our tibia here. This is a coronal sequence. And you can see that there's edema across that fracture line. The reason it's hypointense is because the normal structure of the bone gets compressed. All of those trabeculae are actually being compressed. and it shows up as this dark line here. And then they enhance because edema enhances. You can have all of these inflammatory cells that are reacting, and that all causes enhancement. The same is true for tumor. So this happens to be a tumor in the bone. So these are the same 3 sequences. This is a fluid sensitive sequence. This is a T1 or a fat sensitive sequence. And this is a post contrast sequence. So again, it's bright on our fluid sensitive sequences, it's dark on our T1 sequence, and it enhances with contrast. All right, so that's kind of how we use the protocol to our advantage. So let's talk about mechanism and exam and history. So I'm going to go through kind of these 4 main types of knee injuries and just kind of broke them down into categories here. So, oh no, hold on just a second. I lost my chat here. Hopefully you guys aren't chatting because I can't see it anymore. So if you are, just you'll have to speak up instead if you have questions. So. Okay, so let's talk about injury. So if I give you a history that this patient had a twisting injury while skiing, they heard a pop, they had immediate swelling and a sense of instability, you already have in your head a suspicion of what may be going on, right? I think we've all probably heard this history before. If I add to that some very specific physical exam findings like an anterior drawer and a Lachman sign, you are going to be very suspicious that there's a ligamentous injury. And in this case, the injury is of the anterior cruciate ligament. There are some other injuries in this case, but that is the ligament that is really seen to best advantage. So we talked about that Blumensatz's line a little bit earlier, that roof of the intercondylar notch, and how the anterior cruciate ligament should parallel that line. So you can see portions of the ligament here. We can actually see an area of discontinuity, and then we can see the rest of the ligament here. So not only the discontinuity, but look at this kind of zigzag pattern of the ligament or this angulation of the ligament as opposed to being nice and parallel to this Blumensatz's line. And same is true for the coronal sequence. We actually see this area of discontinuity between the femoral and the tibial attachment of the anterior cruciate ligament. So again, these are both fluid sensitive sequence. Almost all of them will be in MSK. And you're looking for areas of increased signal. So this is an area of brightness. So we have both morphologic abnormality of the ligament itself, as well as kind of some signal abnormality. And it's in the region of the anterior cruciate ligament. And so using our anatomy, our protocol, and understanding kind of the mechanism and the physical exam really help us land on a diagnosis of anterior cruciate ligament.
What's that line called again that we're supposed to?
It's called Blumensatz's line.
Blumensatz's?
Yep.
Okay.
So another injury. So in this particular patient, they had a direct impact to the lateral aspect of their knee from a football helmet. They had medial pain and swelling. They had some instability with valgus stress and some medial joint line tenderness. So focus on our anatomy first, even though this is a really coned down image. You can see that this is the medial aspect of the knee, lots of soft tissue and subcutaneous fat. We can see that we're looking in a region of increased signal in the medial soft tissues here. And our anatomic structure that lives here is our medial collateral ligament. And our history and our physical exam both fit with a medial collateral ligament tear. This is an incomplete tear in this case. The ligament itself should be black in signal, and it really shouldn't have any of this increased signal or any of this thinning. It should be kind of a uniform thickness. And you can see this little bit of this little sliver of fluid. It's right underneath the medial collateral ligament attachment. Okay, moving on. So this is a patient with chronic knee pain. They were a distant runner and they had a recent acute injury. And now they're having catching and locking with pain. They have a positive McMurray's and joint line tenderness. Okay, so again, fluid sensitive sequences. We have a coronal sequence here, a sagittal sequence here. I'll give you a second to look at those and see if you can spot an abnormality. This is a case where there is relatively little edema, so this makes it a more challenging case. You can see that there's a number of structures that we can actually see in this case just on these two images. So if we just kind of take a global look, the bones look like they're normal, right? We don't see much edema in the bones themselves. What we see of the ligaments with our cruciate ligaments and our collateral ligaments, we don't see much edema associated with those structures. Looks like our quadriceps and patellar tendon have kind of normal signal intensity. So that leaves our other structures. And the first one that I'm going to think about is a meniscus in this case, especially in a patient who's having some mechanical symptoms like their knee is catching. So if we look for those nice triangles on the medial aspect of the knee, we can see a nice sharp triangle here. On the lateral aspect of the knee, we see this gray schmutz, but I don't really see a triangle. And so where is that triangle? Well, it's actually been displaced. So it's actually torn in this case, and this is called a bucket handle tear. And the meniscus that's supposed to be out here on the lateral aspect of the joint has actually flipped into the joint space. You can see why that would cause some major mechanical problems in this patient. You should only have one triangle anteriorly. In this case, we actually have two. So one of these is the torn meniscal fragment that is just flipped onto itself, just kind of like a bucket handle can flip back and forth. And causes major problems, requires surgical repair. Here's a couple other examples of meniscus tear. So meniscus can have different appearance. The normal meniscus should always look the same, but the abnormal meniscus can have some different kind of appearances or presentation. So remember, nice sharp triangles. This is our lateral meniscus, so it's a little bit smaller in size. If we compare that to this case of a torn meniscus, this triangle is a little blunted, not too bad, but compare that to this side and we have all of this gray schmutz where we should have that normal black triangle. The reason the meniscus is black is because it's a relatively low fluid substance. There's just really not very much fluid in it at baseline, and so it should be dark on all of our sequences. So again, on the coronal plane, we see nice sharp triangles, both medial and lateral, and we kind of lose that nice black triangle. We have some areas of increased signal within the meniscus itself, and that's a meniscus tear. All right, so in this patient, I had chronic anterior knee pain, and they actually had a fall during a recent run, and now they're not able to extend the knee. So some of the specific tests in this case are something called a straight leg raise. They also had a palpable defect just above their patella. So sagittal sequence, axial sequence, looking for areas of increased signal, and I think that we can all agree there's quite a bit centered out here. So then using our anatomic knowledge, we know that we're in the distal quadriceps tendon here, and we can see that there's morphologic abnormality. There's actually discontinuity of this quadriceps tendon, lots of adjacent edema, and this was consistent with a tendon rupture or quad rupture. So once you lose your quad, it's very difficult to extend your knee, really do much of anything after that. It's not a very common injury, but certainly one that requires surgical intervention. All right, and this is a patient who had a fall while bouldering. They had their legs kind of fully extended. Now they have some point tenderness. They're not able to bear weight. So this is the first time I've shown you guys a T1 weighted sequence. This is where the fat is kind of hyper intense or bright, right? And then a sagittal fluid sensitive sequence. So we're looking for areas of increased signal. You can see that that's really centered here in this anterior tibia. And looking on our T1 weighted sequence, remember that most MSK pathology is going to be T1 hypointense or dark. And we can see that area of hypointensity in the normally usually very fatty bone marrow. And this was a case of a tibial plateau fracture. So this is a pretty typical mechanism. Patients usually fall and just have an impaction injury. You have this very large femur, right, that just kind of smashes into the tibia, causes a little bit of impaction. Lots of bleeding and edema in the bone causes this increased signal, and it was all consistent with a tibial plateau fracture. In this case, it's not very depressed. You can see that it almost has a normal morphologic appearance of the bone and the cortical surface, and so this one may have just healed with non-weight bearing. All right, does anybody have any questions about knee MRI?
I have a question about when we were looking at the coronal femur, they have coronal images of the femur on the meniscus tear.
Uh-huh.
Uh, one prior, I think. One more prior. Right there, yeah. The left image on
Uh-huh.
like the lateral side of the femur, distal femur, there's that like a notch in the physis. Is that normal?
This one, yeah.
That thing.
So this is actually called the popliteal fossa. So what tendon do you think lives there?
The popliteal
The
tendon.
popliteus tendon. Very good. Yeah. So yeah, so the popliteus tendon is the one that courses intra-articular and it actually attaches right there to this little notch in the femur. You can actually see portions of the tendon right here. So yes, that's a normal kind of appearance.
Okay, thank you.
Yeah, good question. Other questions? Okay, I guess that means you're ready for a quiz. All right, so this is the official quiz. I guess you guys are supposed to send your answers to Serena. So I think I have 5 cases for you. They all are similar to the cases that I showed. They have clinical history, some physical exam findings, as well as some imaging. All right, so we'll go ahead and get started. Question number 1. Which normal anatomic structure is here, denoted by the arrows? All right, next question. Sports injuries usually have what pattern of MRI signal abnormality? Question number 3. This patient had some medial joint line pain following a basketball injury. They had a positive McMurray's, and what is the most likely diagnosis? Question number 4. This is a sprinter who had an injury out of the blocks. They were unable to complete the race and had some weakness on knee extension. What is the most likely diagnosis? Last question. This is a woman with knee pain after a twisting injury during a soccer game. She had a positive drawer sign. What is the most likely diagnosis? Okay, does anybody need me to go back to any questions? Okay, I'll give you a minute to send those in to Serena, and then we'll move on. Anybody need more time? Okay, let's go through the answers then. So first case, medial aspect of the knee. We have this thin structure that attaches from tibia to femur. Looks like a ligament. It's the most superficial aspect of the joint, and that is the medial collateral ligament, or the MCL. Okay. Next case, just a reminder about signal. Most injuries have T1 hypointensity, T2 hyperintensity, and enhancement. It's true for tumors, it's true for infection, it's true for trauma, it's true for most things in MSK radiology. So a good one to kind of keep in your back pocket. The third case, so this is a patient with some medial joint line pain. The McMurray's is a specific test for the meniscus. We can see our nice sharp black triangle of the lateral meniscus, and that medial meniscus, it's definitely disrupted. We have lots of heterogeneous signal, some increased signal, and loss of that normal triangular morphology. You can actually see the tear extending into the substance of the meniscus there.
Can I ask a question on this one?
You bet.
I have two questions. One is, where's the patella?
The patella is probably out of plane. So on these sagittal sequences, this is off to kind of the medial aspect of the joint. So if I were to draw a scout line of where this image was, it's as though we took a slice clear out here. So the patella is probably over here, and so we're just out of plane.
Okay.
Does that make sense?
And do you have increased fluid in the anterior joint space?
Yes. So this is a joint effusion. And joint effusions are very common in the setting of kind of any joint abnormality, whether that's arthritis or a ligament tear or a meniscus tear. The body responds by just sending a bunch of inflammatory, markers to help the body heal, and that often results in a joint effusion. And so we have quite a bit of joint fluid in this case here, and it just kind of surrounds all of these recesses. And there's a little bit of joint fluid here as well.
Awesome, thank you.
Sure. All right, and this was our fourth case. This was a sprinter. They were unable to complete the race. So again, this is all about anatomy. We can see there's a lot of increased signal here on this axial sequence. And then on our sagittal sequence, we see this big fluid gap. So we have the distal quad coming down, attaching to the patella, and then we have this fluid gap, lots of redundancy of this patellar tendon. And this was consistent with a tendon rupture. In this case, it's the patellar tendon that attaches to the tibia. And our last case, saw one of these before, very classic history, right? Soccer players and skiers frequently have ligament injuries. The drawer sign, anterior drawer sign is specific to the anterior cruciate ligament. Again, we're looking at that Blumensatz's line. And we can see that there's some ligamentous tissue here, but it's very wavy, lots of increased signal, lots of heterogeneity, and that was consistent with an anterior cruciate ligament tear. All right, questions about those quiz cases? All right, how many of you are doing radiology before I get on my radiology soapbox?
I am.
One.
Simple.
Myself,
with me.
hopefully too, but I'm only a second year.
Okay, that's okay, Sabina. You can own it now.
I'm planning on radiology as well.
Okay, so there's like 4 or 5. That's pretty good. Okay. Well, you've all made the right choice. So the rest of you can hopefully get on board with that. But no, I'm just kidding. Just some radiology soapbox. I think this is useful information for everyone, whether you're going into radiology or not. So you don't have to answer these, but these are actually some data from different research studies that we perform. My specific area of interest is actually in perception imaging. So why we see the things that we see, why we don't see the things that we don't see, and kind of what factors influence those different areas of perception. So long story short, what we usually do is put some fancy glasses on people, on radiologists, and we have them interpret images. And then we manipulate those images by putting in abnormalities that they may expect to see or not expect to see, and we see how they do. So it's lots of fun. So one of the studies we did looked at how radiologists were able to detect unexpected things. So one of the factors that really impacts how a radiologist searches an image is the clinical history. So every time we get an exam or an order for an exam, we get something called an indication, the reason for the exam. Some clinicians are very good about providing specific indications, and some are not. One of the most common indications I get is eval, which is not super helpful in me guiding a search for trying to find something. So any guesses as to what this number might be? So if we don't get the correct history, our ability to detect an abnormality decreases by what %? Any guesses?
33.
33, love it. It's actually pretty close. It's about 40%. So this means that if we're given the correct clinical history, we actually have a much higher chance of making the correct diagnosis than not. And this was true for a number of people. I think we tested about 40 radiologists in this particular study, and you can see that it has a huge impact. So whether you're going into radiology or not, always remember to enter a correct clinical history. It can only help your patients. There is a misnomer out there that you will bias a radiologist by providing clinical history. It's absolutely not true. In fact, the opposite is true. If you provide no information or misleading information, it is actually very hurtful. We're trying to do our best for our patients, so try to provide clinical history. Okay. So part of this is respect. So some people don't know what radiologists do. In fairness, I had not much of a clue what radiologists did in my first couple of years in medical school. But it's actually a pretty long training period, and there are actually a lot of different subspecialties of radiology. So the average radiologist trains for how many years? Does anybody know? Those of you going into radiology should probably know.
Guessing
like 6.
It's
5 to 6?
Yeah.
5, 6.
6, absolutely. So 6 years, though the average residency spans anywhere from 3 to 7 years, with some of the more, subspecialized surgical residencies being 7 years, and radiology is right up there. It's a pretty long residency. And the reason why is there are 10 different subspecialty areas of radiology. So I practice in one of them, right? And I do this every day. There are 9 other major, there are several minor subspecialties of radiology. The residents have to become proficient in all of them. And that's part of the reason why residency training is so long. Perspective. This was an interesting one. We did some research on just watching radiologists and how often they get interrupted. Any guesses for how often a radiologist gets interrupted in an average day?
Every 20 minutes.
Every 20 minutes, it's a good guess. Any guesses on how many phone calls in a 12-hour shift?
13.
Guys are going to be blown away. So these are statistics from the residents on call. So at the University of Utah, our residents take independent overnight call. What that means is that they are in the hospital solo from about 10 p.m. until about 8 in the morning or 9 in the morning. And so we watch them to see how often they got interrupted by a phone call or a consulting clinician or by some sort of other task, somebody else asking them to do something else. So they get interrupted often. You become great at kind of doing many things at once in radiology. It's a very busy subspecialty. So there's a lot going on. And in fairness, there's a lot of phone calls. It's mostly kind of interruption. Radiologists are happy to consult with clinicians, but when somebody's taking 25 minutes on the phone to try and describe what's going on with their patient, you might understand why people get a little bit short on the phone. So just things to remember, it is a very busy subspecialty. So whether you're calling for a consult or asking for help, we want you to absolutely, talk to the radiologist, but please just keep in mind that sometimes there's one radiologist caring for all of the patients in the hospital. All right, and last but not least is feedback. So during residency, our residents interpret exams and then they receive feedback on those from an attending physician. That's typically how most radiology residencies work. When you get out into the world and you're reading exams, you no longer get that feedback. You sign a report and it goes off into the world. A lot of times clinicians may have additional information. They may find out something after the fact that kind of changes the interpretation of an exam. A lot of times we miss things because we don't have all of the clinical information. And that feedback is actually helpful for making us better as radiologists. So we all want to get better at what we do, but that feedback can be delivered in many ways. Just remember, when you're getting feedback, there's things that are nice to hear and things that are not so nice to hear. So just a reminder that you missed this is not really a suggested mechanism for feedback. But as you go out into the world and are practicing in your different subspecialties, just a few things to keep in mind. Chances are that you will interact with radiology somewhere along the way. Most people are very laid back. It's a pretty easygoing subspecialty. So I think that's all I have for you guys. Do you guys have questions for me? Other things I can answer?
I did have a question. So with the injuries that we talked about in this lecture, do we need MRI or imaging in general to make the diagnosis for these injuries, or can we make them the diagnosis clinically?
So it depends. The answer is yes and no. When most patients come in with, for instance, an ACL tear, and they have a very classic history and a classic physical exam, the MRI is not necessarily helping the orthopedic surgeon make a diagnosis of ACL tear. It's evaluating for other concurrent injuries. So there are some cartilage injuries, there are some very subtle ligamentous injuries that are very difficult to see arthroscopically. So a surgeon may already know they're going in to fix the ACL. They may not know there's a large cartilage injury that also needs to be addressed. And so it just really helps with that preoperative planning and identifying other issues. Sometimes a person's knee is so swollen that they can't actually perform a good physical exam. In those cases, they don't even know if the ligament is torn or not. And so it is kind of an area that helps guide clinical management. It may not always provide the precise answer, and it may not always add information that wasn't already known. But for most of our cases for sports injury, those patients all receive some sort of MRI or advanced imaging before they go on to surgery.
Okay, thanks. That makes sense.
Sure. Other questions? All right. Well, thanks, you guys. Hope you enjoy the rest of the course, and take care of yourselves out there. And if you need anything, like I said, most everybody's very laid back and easygoing. Feel free to shoot me an email or reach out to other faculty or residents. So, okay, take care.
Thanks, Dr. Mills. Bye.